we will move ahead to our next session, which is on Ayushman Bharat Digital Health Mission, Transforming Healthcare Spectrum. And for this session, may I request Mr. Arun Goyal, Chief Information Officer, Sir Ganga Ram Hospital, to please join us on stage. Welcome, sir. Mr. Yasin M, Choudhary, Mission Director NHM, Jammu and Kashmir, and Dr. K Madangopal, Senior Consultant, NITI Aayog. Thank you so much, sir, for joining us, and Dr. Ravi Gupta, who will be moderating this session. Thank you. Over to you, Dr. Gupta.
Hello. So, welcome our esteemed speakers and welcome our esteemed delegates, and we have a very, very interesting panel. And I have suddenly taken over as a moderator from Mr. Arun Goyal, because I wish that he speaks instead of he just moderating. And Mr. Arun Goyal has been a part of the NDHM and has been involved in the designing of the architecture of NDHM itself. So great to have you here with us, Arunji. And we have with us Yasin Choudhary ji, who is Mission Director of National Health Mission, Jammu and Kashmir. You heard him in the morning. Thank you, Yasin ji, for joining us again. And we have with us a very, very important speaker, Dr. K Madangopal, who is the Senior Consultant of NITI Aayog. Namaskar, and thank you for joining us. And may I request you, Gopal ji, if you like, इस session के लिए अगर आप mask हटा दें कुछ देर, so that interactions happen much more freely. So I will start with the requesting Dr. Madan Gopal, who is the Senior Consultant from NITI Aayog, and he handles the health vertical at the NITI Aayog, to speak about how he is seeing the digital adoption in the health ecosystem in India, both in the government and the private sector, and how is NITI Aayog thinking about this whole issue of healthcare and overall healthcare reforms itself. Over to you.
Thank you, Gupta ji. Good afternoon, everybody. Thanks for this opportunity to share my thoughts on how the digital mission has shaped up and what we are looking forward and how it will be evolving in the coming future. So as we know that as a commitment towards health, so it took around 50 years after the constitution of WHO to arrive at a consensus what health means. So we have agreed to a definition of health during in 1978. We have agreed that a definition and consensus was agreed, and a modality of achieving a particular state. That means we had that approach of health for all by 2000 through a primary healthcare approach. And we have done substantially good work in achieving this health for all targets. Then the goalpost was raised in the form of Millennium Development Goals, where we try to achieve to the same approach, that is primary care approach. And we have tried to see that how we reached that goalpost, which were there, some indicators were there. We do have some vehicles in the form of RCH program, the NHM program and other things. They were vehicles which were targeting and having the approach of primary healthcare approach, and then we tried to see that how this was to be achieved. Then subsequently, when the Sustainable Development Goals came and the National Health Policy was framed, in which we have envisaged a digital architecture connecting the citizen, a citizen-centric digital architecture for rollout of the health. And as the goalposts were changed, then the approach was changed from primary healthcare approach to comprehensive primary healthcare approach, wherein in the sub-centers, the peripheral more institutions, we were providing 6 sets of services, now 12 sets of services were there. This kind of expansion has happened, but there are certain limitations. If you want to have a scale in expansion, you should be using technology, and the digital innovations were one of the key for that. WHO do have a digital innovation thing. They talk about the digital health, they talk about the M-health, they talk about the other use of the technology and other things. Having said this, we should understand how the things have evolved in the country. One of the things is we do have, you name a program and you are having a platform and a portal for that. You name a malaria program, you are having a malaria portal, malaria program portal, you have the RCH portal, you are having mother and child tracking system, you are having TB portal. These all the data sets are available. You are having immunization data sets. All these data sets are available, but they don't talk to each other. So that was the challenge. When Ayushman Bharat was launched, because as I mentioned, the approach was changed from a primary healthcare approach to comprehensive primary healthcare approach. To achieve that, we required certain tweaking into the existing network, which has evolved to cater to the population right up to from a village level to medical college level. I think some interesting talks are going on. I think I should be part of that talks. So they are distracting me. So I don't know who is, if they are not interested in listening, then I should not be called to the meeting. So it is distracting me, madam. I've been looking at you and thought that you would be listening. If you're not interested, no issues. That's one thing. As we have evolved, it's not that with this kind of simplicity, you would be able to understand the health system. It's very complex. All the health system, it has evolved, it is working in silos. The private sector, they claim that we are providing the health care. But if you look at the footfalls in the private and the public sector, is more or less 50-50%. But the expenses which happens, more expenditure happens in the private sector. That is 70% of the healthcare expenditure happens in the private sector. And most of it coming and financed by your out-of-pocket expenses. We have brought out a report in 2019 wherein for the first time we have identified that the health system is fragmented. That means if 70% of the care is happening through out-of-pocket expenses, that means 1.4 billion people, they are chasing around 1 million of healthcare providers for seeking their care. That kind of fragmentation is there. If you talk about the TB, we did a study for that. For getting to the right place for getting treatment, the person has to cross at least 8 to 9 places to reach to the right level. That's another thing. When we have changed the approach from primary care approach to the comprehensive care, the structure was to be changed. When the structure was to be changed, a lot of tweaking was required. From disease, we have gone to the health. From health, now we are moving towards the wellness and the other components. We have to understand and appreciate these, otherwise all would be just details and you will be just locked up into the jargons of the technology, the digital health, and in silos that I am doing this thing and other things. We should understand the bigger game in which how the things are operating. That's one thing. When we have shifted from this comprehensive care, from disease to health to wellness, now you have seen that we have now upgraded our sub-centers, which were already there, to provide 12 services to the sub-center instead of 6. Now that has been upgraded to 12. And for that, where without is required. Hello. If you appreciate this thing, then you will understand where the space the private sector can rope in and how the digital things will come and how the technology will come in aiding in providing these 12 services through these health and wellness centers. That's one aspect. The second aspect was that how to provide the secondary and the tertiary care services. If you look at any government sector, we have established a network of institutions, but the reach of the people is not there. To bring that, we have roped in and started the scheme Ayushman Bharat PMJ program. Previously, the experiment with RSBY was very helpful. It has given us lessons, and to address most of the shortcomings of that, the program was launched as PMJ program. PMJ program at that time when it was launched was having two components. One is the Ayushman Bharat PMJ, Pradhan Mantri Jan Arogya Yojana, which was more or less focused for providing secondary and the tertiary care. And the second aspect was PMJ Health and Wellness Centers, which was envisaged as a gatekeeper or providing primary healthcare services, so that the load of all the services is not there. I'm just giving you a background that how the digital thing came up, how we have enabled the digital thing. When these two programs were running, now when the Ayushman Bharat, when we migrated from RSBY and upgraded ourselves to launch this PMJ program, we were having the challenge of how to have a technological solution for that, because handling that number of data, that is 50 crore population data, is not a small job. if you are able to handle 50 crore data, you require a technology. When we had the Clinical Establishment Act, which talked about managing the patient records to electronic health record, that's there. But things have not moved in the right direction. I don't know why this has not. That's a matter of further deliberations and discussion why this thing has not happened. Still, we are struggling with the electronic health records. At that time, the country has taken was standardization of the this health record. We had that SNOMED CD license for all of the country, including the private and the government. But I don't know why this has not happened. That's a matter of discussion and deliberation. But second thing which has happened after that, when the PMJ rolled out and we have evolved a digital blueprint which talked about the digital health architecture for the country and how the future will be evolving. A part of the blueprint is being now implemented as a National Digital Health Mission, in which we would be digitalizing a patient individual record. We would be individualizing and giving an ID to the doctors. We would be giving an ID to the health institution. We have started with the National Health Authority having enrolled around 20,000 plus hospitals. We have started with that. But eventually the scheme and the vision is to have an electronic health record. The digital IDs would be there, which would be upgraded, and now we will be converting this digital ID and seeing that how the digital health record is being made. In the Scandinavian country, in the European country, they are also struggling and to have the electronic health record. In the European, the NHS system, they have also attempted, but due to certain reasons, the things could not move as desired. That's the thing. But still, we are evolving. We have learned from them, and we see that how we move in that direction. That's one thing. Second thing is, I have mentioned about the health and wellness centers. We are having around 1.7 lakhs health and wellness centers. And everybody talks about shortage of trained medical personnel. At the centers, when the COVID came, it was an opportune time for us to release the telemedicine guidelines, which have opened the floodgate for telemedicine consultation and everything. Now you would be having teleconsultations and other things across. Many providers are there. But the challenge is that we have opened that thing. Now we have to take it forward, see that how it is better utilized at that level. We are trying to see that the second component, the primary healthcare component, we are trying to see that how enablement of the telemedicine guidelines can leapfrog the technological innovations, the digital health, in providing services to that masses which are deprived of the expert services. That's another area which is coming. Simultaneously, both are coming, and now we are envisaging, if you look at the our document, that is Disease Surveillance 2035, where we have envisaged that we would be using the electronic health records for disease surveillance also. That's our vision, to see that how we leverage the telemedicine, the digital platform and the digital blueprint which is available for seeing that how the country progresses towards that. The example of technological leverage you have seen, how we have managed the COVID, how we have seen managed the surveillance or disease surveillance during this pandemic time. So you see that the future is moving in that direction, and now I'm very confident that we would be able to see and progress in that direction. I will stop here, and I would be willing to take questions after all the deliberation. Thank you very much.
Thank you, Dr. Madangopal. I think you have very well explained about how the whole digital journey in healthcare policies in India, and also at the implementation level, how the things have progressed. And I think it was highly detailed and comprehensive. So thank you for putting that context in this whole discussion, which was very, very important. Let me request our next speaker, Mr. Arun Goyal, who is the Chief Information Officer for Sir Ganga Ram Hospital. And you have been part of the NDHM architecture debates and deliberations, and you are now part of the hospital itself. So what are your views and perspective on the Ayushman Bharat digital health mission, and so you can give a perspective both from a policy angle and the implementers angle.
Thank you, Mr. Ravi. And I would thank Dr. Madangopal specifically to give the insight about the health tech policy, government health tech policy. Sir, you were right when you mentioned that in 2011 you came up with the India health policy, and we failed somewhere down the line to implement across in the government to implement it. But simultaneously, I would like to thank you and the government to come up with the NDHM project, which is deliberated after studying 5 countries' health program, which includes Canada, NHS, USA, Singapore, and Australia, which were the part of health blueprint, the NHM blueprint, which is available on the NHS website. So I was fortunate driving as a project director the NDHM project in NHS before Prime Minister inaugurated the NDHM project with the new name of Ayushman Bharat Digital Mission. So far as the data integration is concerned, which you mentioned about the EMR and segregated data sitting across, and the challenge was sitting across the industry, how to have a integrated data of the patient across the industry. So technically we thought through, and we considered the security and data privacy also in consideration while keeping the patient's data along with the patient's information at a central place. So in the NDHM blueprint, you can see that the whole scheme is a voluntary, and we took it as a segregated interoperable model into the NDHM, wherein patient data would be sitting at the respective hospital and the health service provider. No data will be available with the government as per the PDP policy. So government will not be having any patient data from that perspective. So patient privacy has been taken care of at most from that very perspective. And even though the patient's data is sitting with the service provider, the hospital, the pathology lab, or anybody, the pharmacy, there the data of the patient will also be kept with the consent of the patient. So that provision has been made that patient consent is required to keep any data, provided if some data which is required for any research policy or anything which is required from the government regulatory perspective to keep that data is by default will be kept, and patient will be informed about that thing. Like, you would be aware that, in some of the tier 4 hospital or the patient care, you need to have patient data for the clinical trial purposes. So their informed decision or informed information is with the patient to keep the data from the regulatory perspective. So from that perspective, the whole data is sitting with the healthcare provider. The link of all the data would be sitting at the NHA centrally. So based upon the patient consent, the health ID will be provided by the patient, and along with the health ID, he will provide the consent. That consent will be vetted by the NHA through UID and other IDs, and OTP will be provided to the healthcare provider. Based upon that, the respective health records will be released from the respective health facilities. So I'll just give you the example just to make it more clearer. If a patient has gone to the Tata Memorial in Bombay and visited AIMS in Delhi or Medanta in Delhi and got the test done at Dr. Lal's lab or a Mahajan Imaging, data will be sitting with these respective facility. Patient may not want to share all the data with the clinician whom he is consulting. So he may choose to only share the Medanta data and Dr. Lal's data, and rest of the data he doesn't want to share. So he will not give the consent to the clinician. He will only click for these 2 records, and these 2 links will be released to the Medanta and the Dr. Lal Path Lab, and clinician will be able to see that. So that provision has been made. So this is the high level 36,000 view I have given to you about the NDHM. Furthermore, NDHM, while designing the NDHM, it was thought as per the guidelines of the government that other functionalities like, sir was mentioning about the telemedicine, telepathology, e-pharmacy, etc., being kept into the mind, so that patients or the remote patients are able to access the health. So it has been provisioned into the architecture that remotest patient should be able to access the health facility, With that thing, sir, I think you would already be aware that in NDHM, all the union territory, all the government hospital has been 100% enrolled into the NDHM, and NDHM project has been 100% implemented in all the hospital in all union territories. So this is the very good program, and I was a panelist into one of the international panel in the Singapore, and I proudly said and shared that what structure NDHM has adopted after evaluating all the countries, 5 countries model. We are the only country which have come up with the patient's consent model, where patient has been empowered with their data to provide the consent to share their data, and government has very limited control over the patient's data, because patient has every data sitting with them. We have kept the provision that patient can store that data at some health locker, so that has already been provided by the government. So that facility is available. Patient can revoke the consent with the respective hospitals. That is there. All the facility provided, the remotest facilities in the government or in the private, has got a privilege to use e-hospital sort of EMRs or the HIS within the NDHM, so they can use that also. All the international guidelines, be it the ICD-11, SNOMED CT, LOINC, HL7, all standards, global standards have been followed by this in the secure data, in the data transmission, data security, data at rest. All global standards have been followed and kept in mind that all these guidelines are there, and global standards are followed under the NDHM architecture. I'll stop myself with this and hand over to
Thank you, Arun Goyal ji, for detailing out the various architecture details of NDHM so well, and you have also highlighted the various unique features of it. Let me request Shri Yasin Choudhary ji, who is the Mission Director of National Health Mission, Jammu and Kashmir, to actually talk about NDHM implementation challenges and in fact opportunities and success stories from his state.
Right.
Yeah.
Thank you, Raviji. Firstly, the brief which Dr. Madangopal gave earlier was a very informative one, because very few people actually understand the linkage between primary and secondary care. I spoke about continuum of care earlier, and whenever anybody thinks of Ayushman Bharat, the first thing that comes to their mind is ABPMJ here. Whereas the reality is that when the concept of Ayushman Bharat was designed and the way it has evolved, it actually has 4 pillars. The health insurance scheme is one of them. The digital mission is the second one. The comprehensive primary health care and through health and wellness centers is the third one. And now there's something called ABHIM, Ayushman Bharat Health Infrastructure Mission. However, ABDM remains that connecting link. Now coming specifically to how we are implementing it on the ground, and Goyalji here was involved in the developmental phase when they launched the blueprints and all from NHA's side, and we were still trying to grapple and make sense of what is it all about, how is it going to translate on the ground. So first and foremost, I must hat tip to Team NHA for giving us extremely off-the-shelf, ready-to-use model. There are many other areas where the UTs or states have to build their own IT expansion or take care of some sort of software extension at their own end. But this is an end-to-end implementation module, and all we have to do is basically just open a browser link and you're ready to go. Though it's not obviously that simple, but I'll break it down. Firstly, with regard to enrolling everyone. Dr. Madangopal also spoke about something which I was talking about earlier, that for us to have at least sizable set of records to begin with, we should dip into the existing RCH, HMIS or numerous other portals which NHM is running throughout the country, because these are the most primordial, most primitive data collection sets that we have been generating for more than a decade now. It's very valuable data, it's unstructured, it's lying there for ages, but it's the only head start that we can get. Second, it also remains the only way through which we will be able to continuously embellish whatever data we have. So for instance, even if a patient is getting an ABHA ID but not actively using it in every OPD, IPD consultation that he gets, some of these portals will continually keep adding to it. The third thing is whether how do hospitals start logging the data. That will be through the HMIS integration into ABDM, and I spoke about the interoperable platform and the plug and play model there. Now this is where I think the levy breaks, because that's where the hardware and the software interaction comes in. And while I remark that Praveen Giram sir very confidently says that it's a plug and play model, anybody anywhere using any sort of HMIS that can be easily made compatible with ABDM and integrated. That process has been successfully done in many hospitals with their existing HMIS software systems, no matter who developed them, where they were developed, and it still goes on. In Jammu and Kashmir right now, our focus is actually on this particular point. And what we had done is also make use of, because to be honest, we didn't had HMIS in most hospitals back there. Only the tertiary care hospitals were using them, and that in a fractured manner. But we understand and realize this opportunity here, and this is a sort of message that I wish to share with all of you. You all are representing numerous medical and health related enterprises from across the board, across the country. I very passionately believe that ABDM is the game changer. It is going to be the biggest disruption in the health sector, and we just can't avoid going digital. So if you wish to onboard yourself, do it as soon as possible, because the sooner you do it, the more benefits you'll be able to reap out of it. Coming back to HMIS integration, what we are trying to do in JNK is basically make sure that whatever HMIS capacities we are building are ABDM compliant from the start. So we have a greenfield opportunity of sorts. Also, just bringing in and ensuring that we have ABDM compliant HMIS, would that mean that patients and doctors are actively using their ABA ID or HFR ID or HPR ID in that process, actively building digital records? That's not a certainty. However, what we've seen with ABPMJY is that there's definitive IPD record building that is happening. And if all that record is getting added to the patient's ABA ID DigiLocker, then of course we have immense data to start with. It's all about popularizing the usage. And right now we are pushing it, but in a while it will start flying itself, because hospitals and patients both won't have an opportunity, both won't have any other option but to actually make use of it. One last point regarding patient consent, and Goyalji spoke at length about it. Yes, that is very critical. And in the last session there was a very interesting remark by a gentleman who said, in the absence of a very strong personal data protection law in the country, we are not sure exactly how we are going to implement ABDM and all. And then he mentioned, how Ola and Uber do it and all. और उन श्रीमान से मेरी बात हुई थी बाहर, और मैंने उन्हें कहा कि जिन ओला उबर की आप बात कर रहे हैं, वो यूज़र का कंसेंट अपने ऐप के सेकंड पेज में ही ले लेते हैं जब आप वो चेक बॉक्स करते हैं ना कि आई एग्री टू द टर्म्स एंड कंडीशन. दैट्स द प्राइवेट डेटा यूजेज कंसेंट दैट यू आर गिविंग. हाउएवर सरकार में हमें ये हमारा मतलब आइडियलिज्म है कि नहीं, हमें प्रॉपर बायोमेट्रिक ऑथेंटिकेशन के साथ ही यूज़र कंसेंट, प्राइवेसी कंसेंट लेना ज़रूरी है. Is that a folly for us? Does that make our processes lengthier? No, it doesn't. It only makes them more secure. And I think that's one cornerstone which R.S. Sharma sir has very strongly emphasized upon, because even with the huge success that is Aadhaar, we still have critics who continue berating us over data privacy, and all regards to them. They're activists, that's their role, and the many countries in the post-Snowden era who have talked about data privacy, who have faced serious data privacy issues. But, and again, as R.S. Sharma says that when we build for something as grand and visionary as ABDM, then we build for three things. We build for universality, we build for robustness, and we build for interoperability. And it's the spirit that we think that that privacy consent issue will continue to remain for ages to come. But just like you have gotten used to check boxing that mark, on the second page of Ola Uber app, in the same way, you will get used to dropping your biometrics at every OPD or IPD clinic that you will visit to unlock your DigiLocker. It's as simple as that. However, we want you all to do that in an informed manner, in an aware manner, so that we have a active citizenry which is making proper and full use of ABDM. That's all.
Yeah, sure.
Can I add one thing to Dr. Yasin Singh is, sir, when you were mentioning about the DigiLocker access is fully available with the patient, nothing in the control of the government. So whenever you are visiting to the clinician or the hospital, the data goes and sits with the patient's DigiLocker. So I just wanted to make that clear.
Perfect. And thanks, Yasin ji, for highlighting this issue about data protection, data privacy, and government versus private issues. Let me request Dr. Madangopal to talk about the things beyond digital, that what all is happening in healthcare policies. Like a lot of action is happening in the digital arena. What all is being thought beyond digital in overall healthcare reforms or healthcare policies, if you wish to highlight that part also. If you
This is a very interesting question because we have been talking about healthcare reforms. If you look at the reforms, it started before independence, and we do have a committee called Boer Committee, which has given how the system will look like. And at that time, it was envisaged to have at the block level a 2,000 bedded hospital. It's still a distant reality. Now we are trying to see that how we strengthen our block level, that means the community health centers. That's a different thing. One of the things which has been talked about is how to implement and how to realize the goals which have been envisaged in National Health Policy 2017. And we are all working towards that. In healthcare reforms, you will talk about the major reforms will come when we have the capacities to regulate and see that how regulation of the acts, regulation of the prices, regulation of the quality. These are the three areas where we have to work. If you talk about the quality of health services, are we able to ensure quality? We are only talking about patient safety norms, and patient safety norms are there in the form of NABH and the other accreditation criteria. They talk about the patient safety, but they don't talk about the patient outcomes. What are the outcomes when we are envisaging about this? They say that NABH accredited hospital, whether they are having a good outcome or not, we don't know. That's a quality aspect. They are silent on that. The second, because I'm just citing my example when I was working in a state, we had the first public sector hospital to have an ISO certification. After ISO certification, things have deteriorated, not improved. It was a vibrant hospital in a tribal district in the central part of the country. But things have deteriorated after that. People thought that ISO certification they have got. Then after that, it's now NQA certificate, that's equivalent to NABH certification for the public sector. After that, things have not improved. The outcomes, they are not improved. We have been, when I was handling the RSBY affairs before this current assignment, at that time we have tried to see that how the quality initiatives can be made a movement. At that time, when majority of the hospitals were small hospitals, we tried to dilute the criteria and told that instead of having a full NABH accreditation for the smaller hospital, we can have a staggered criteria in the form of entry-level accreditation, progressive, and the full accreditation. Full accreditation was already there. We have attempted and we have made the entry-level accreditation way back in 2013. After we have left, nobody attempted at the progressive level accreditation. So we do have for the smaller hospital, which majority of the tier 2 and tier 3 cities are having is 50 plus bedded hospitals, and everybody is attempting at entry level accreditation. Nobody is talking about progressive and the full accreditation for the hospital. Not to talk about the full accreditation which NABH is having. Despite 15 years into the quality thing, you see how many hospitals are having these parameters for patient safety, not to talk about the outcomes of the disease and other things. That's one thing. Second thing, regarding the regulation aspect, that's the area where a lot of work is to be done. How to regulate the establishments, establishment means the healthcare establishment as well as the ancillary establishment associated with this. Do we have the capacity to regulate? That's an area we are thinking and see that how we can work on that. The other area is see that how to regulate the prices. In fact, there has been in the previous the economic advisor was there. He has also mentioned about the price control in this. We have tried to have the price regulation in the form of price control for price regulation for the stems. But the procedure cost has not come down. It has invariably remained the same. Previously, patients were having 1.5. Now the similar thing is there, but the stent cost is mentioned as 26 to 35,000 rupees. But it has not come down. That's the biggest challenge we are grappling and trying to find out ways to address these issues. When we were talking about developing this PMJ program, as we were involved in designing the packages, there were a lot of resistance coming from the big hospitals in this. But I was very clear that this is meant for the tier 2, tier 3 cities, and it's a boon for the tier 2, tier 3 cities. It's quite viable packages. It may not be viable for the tier 1 cities, but it's quite viable. And as the things are evolving, we have to have some packages to start with. As the things are evolving, we do have some information about what could be the actual rate for this. At least some rate and other things, the price control, automatically it's now happening. That's another thing. This is about the secondary care and other thing, but still we require, if you look at the way, if Ayushman Bharat we are having 50,000, I'm just giving some data points to ponder and think. We have 50 crore beneficiaries in Ayushman Bharat, the PMJ program. And if you look at the NSSO data, those whatever the data is, NSSO data, that's the inpatient hospitalization is around 3% per year. If you look at if 50 crore people, that means 1.4 crore beneficiaries, if they come to the hospital, all the 3% will come to the hospital. Do we have enough beds to cater to these patients, apart from the other services? We have to think on that. That's why lot of requirement is there to invest into the beds in tier 2, tier 3 cities, so that in case of required need, we would be able to cater to this requirement. That's one thing. Do we have the adequate manpower to man all these things? We always compare with NHS, we always compare with the Western models. In the Latin American countries, which are more or less lower, some of them would be lower middle income countries like India, there are a community health center. In our community health center, we do have a staff of around 50, including the ministerial staff and other people. But their community health center having a 30 to 50 beds was having around 500 people, 500 staff. I don't know. Where is the disconnect between, we want to multitask everything rather than specializing. We have to see that how we invest into the manpower so that a better services are provided. So these are all the thoughts. We have to find an answer to this, how to address these gaps. If you want to talk about a new model, there's no particular model. Things have evolved in the country. They are working in silos. As I mentioned earlier, things are happening in fragmentation. We do have mom and pop shops. That means mom and pop shops means the father is a doctor, mother is a doctor, their children are a doctor, they are running a shop. And they are fending for themselves. They are following all the rules, all approvals they are taking, and they are negotiating with the patient for the services, because most of the services are happening out of pocket. How we defragment this thing, that's a challenge which we are facing, and we see that how we address in the coming years. These are my personal thoughts, not this. We have been associated in bringing out that report, status of the health system in the country way back in 2019, where we have find all these things, and we are trying to defragment. Otherwise, people never used to talk about silos and fragments. You have to see that how you identify that. If the providers are defragmented, then the negotiation power and other things, they will definitely improve. Otherwise, we will always be grappling with the issue, quality of service. I provide more quality, he provide more quality. I am an ABDHM accredited hospital. But after getting accreditation, whether our quality and the outcomes improves or not, that's a question we have to answer. We have been pushing, saying that we should be having some outcome parameters, but very difficult to measure. But in the Western countries, they have an outcome parameters. And they do have, because their system is different, a sizable population is given to a particular hospital, and the hospital is assured about the volume. But in our country, we can't assure a volume to any hospital, any institution, or any providers, or neither an insurance company. So these are few of the thoughts. We have to see that how we find an answer to all these things. I think I've been fair enough to give response to your question. Thank you very much.
I think you have raised a lot of deep issues which affect our healthcare ecosystem. Thanks for doing that. And we are at the concluding stage of this session. So I will request our speakers to give their concluding remarks briefly about how are you seeing the collaboration between government and the private sector for improving the healthcare access in India and quality also, of course. So let me request Yasin ji to take over first.
Right. Thank you. So, of course, Dr. Shab just touched upon the whole issue of how we've gone wrong with the national health policy or rather the proposed plans, and more specifically weren't able to scale them up to the extent that we wanted them to. We touched upon this aspect of how for a mission like ABDHM, the government is playing its role in building the IT backbone, while the private sector, the numerous private hospital chains across the country, the numerous diagnostic and pathological labs across the country do have a role to play as well. And I want to conclude by actually exploring this particular remark that ABDHM is not just another Sarkari scheme that all of you, most of you who are from private hospitals wouldn't want anything to do with. It's not also something that you would have to adopt at the cost of displacing whatever existing HMIS or IT capacity you have. All we are asking you to do is to just get an HFR for the hospital facility registry ID for your hospital and HPR IDs for your doctors. That's it. The process is completely self-service based. You don't even need the NHAs or the SHAs IT teams to come into your hospital and register you. No, a doctor will just have to open a web browser, log in for just fill in details for 3-4 minutes and get an HPR ID. Same for the HFR ID. The point here is that the plug and play model enables you all to onboard seamlessly. There may be some glitches here and there, but the end process is very rewarding in the sense that whatever you are doing will additionally log numerous entries into the patient's digital health record, and that is a very important aspect of health sector record building, which we are looking at. And let me and the first question that comes to your mind is, why should I put in that extra effort to get those IDs and get my patients' records digitized and all for that matter? See, it's something like karma. It's going to come back to you, because if you plug into the interoperable platform, not only would you be sharing the records of your patients, but also be able to access the previous records of your patients generated in other private establishments. So it's a win-win situation for all of you. So once again, I am not trying to be the flag bearer of ABDHM, but as the only government officer on this panel, I once again invite you all to be a part of this transformative journey. Thank you.
Fantastic. Thanks, Yasin ji, for highlighting that why the private healthcare providers should be part of this ABDHM. Arun ji, over to you to give closing remarks.
I would say that I would request, as Dr. Madangopal is here, who is from the NITI Aayog, and Dr. Yasin. I would request, sir, because I've been part of ABDHM, and you certainly mentioned about the challenges in the implementation as well. Would request that we should revisit the ABDHM model in the implementation at the hospitals, wherein when you see that the small hospital, nursing home, as you mentioned about, or the big hospitals, need to see that what are the challenges sitting out there and why they are not adopting, and what push from the government and the support from the government is required for the adoption of ABDM. As Dr. Yasin mentioned about health ID creation or health facility registration or health professional registration, those are not challenges with the hospitals. The challenges is still how data will get exchanged between the two hospitals. So the health exchanges are not available. Huge investment is required for that. So that challenge or that particular middle layer, I would request that if we can have some light over there on the policy point of view, because I am a CIO of one hospital here, I see challenge sitting out there. If I do all those things, how my data will go to the other hospitals?
Because if you look at the National Digital Mission, one of the aspects is right now, in the first phase, they are focusing on generating the IDs of the patient, hospitals, and the providers. Now, in the second phase, linking these IDs with the electronic health records. The moment that linking happens and the electronic health records are created, I think you will get the answer there, how the interoperability between the institutions can happen. Because this is a major challenge, how to translate the IDs, our IDs, into the electronic health records. So that's a challenge which we are struggling for the last 1 decade, and most of the countries across the world, they are struggling to have a proper electronic health record without compromising the patient security and the other things. NHS faced, they have also tried to experiment with this, but they could not manage because of some security related issues, and there was some mismanagement of the patient data. So they could not succeed, but taking clue and lessons from there, we are going slow, we are creating an ID. This ID, after this ID, I think work is going on for creation of the electronic health records. After the electronic health records, would be having interoperability among all the hospitals.
Great discussions. Thank you, our esteemed speakers, for this amazing panel. Let me hand over to Garima. Yeah.
Thank you. Thank you so much to all the esteemed panelists for the insightful discussion points that you've shared with the gathering here. May I request the hostess to please bring up the mementos on stage, and I would request Dr. Ravi Gupta to please felicitate our panelists here. Can we have the mementos, please? Dr. K Madangopal, Senior Consultant, NITI Aayog. Thank you so much, sir, for being here this afternoon with us. Can we have a round of applause, please? Thank you. Mr. Yasin Choudhary, Mission Director, NHM, Jammu and Kashmir. Thank you so much, Mr. Choudhary. It was a pleasure having you with us. Mr. Arun Goyal, Chief Information Officer, Ganga Ram Hospital. Thank you so much, sir, for your presence. May I request the panelists for a group photograph along with the eHealth magazine that's been catalyzing healthcare innovation since 2005. Can we have the magazine on stage, please? Thank you. Thank you all the panelists for being here with us. Thank you.